So thank you everyone for attending the Addressing Birth Equity and Family Wellbeing through Cross-Sector Alignment and Policy Solutions, a collaborative opportunity to be able to share from Evidence for Action, Policies for Action, Systems for Action, a Robert Wood Johnson Foundation for Action Research Program panel. The National Research Program Office of the Robert Wood Johnson Foundation has these programs to support research across the country studying how different policy, programs, and systems impact health equity and population health. These 4 action programs have invited researchers from each program to join this panel and share their experience and findings from their prospective projects in the birth equity and family well-being space. Just to give a quick overview of our agenda for today, I'm Andrea Serano with Reaching Our Sisters Everywhere, a national nonprofit that addresses breastfeeding inequities. And with me, I have the wonderful panelists from each of the Evidence for Action, Policy for Action, and Systems for Action. Following the panelists, we will also have a Q&A. And so as you are listening through today, and you have any questions that you can think of, please do not hesitate to put them within the chat box. I'm working collaboratively with some phenomenal individuals that will ensure that we are able to capture your questions and be able to read them off when we get to the Q&A segment of this webinar. So on the panelists that we have today, we have Dr. Malini Nijagal with the Evidence for Action. In lieu of reading full bios, I'm gonna go ahead and go over each of the panelists, and as each one discusses their project, they'll be giving an overview of their bio, just in the essence of time, because we wanna make sure we have room for the dialogue. We also have Dr. Felix Muchomba from Policies for Action. And we have Dr. Venice Williams from Systems for Action. With that, I'll give an opportunity for each of the projects to give have about a few minutes to not only introduce themselves, but also introduce their project. And we will be starting off with Dr. Nijagal.
Thank you so much, Andrea. Really appreciate the opportunity to be here this morning with everybody. So as Andrea said, my name is Malini Nijagal. I'm a professor of OBGYN at UCSF and a practicing obstetrician, and primarily focus my clinical practice on caring for pregnant people with systemic barriers to care, predominantly being living on low incomes. And the main focus of my work has always really been around maternity care design. So how we can create sustainable systems of care that are high quality and valuable, really defined from the perspective of pregnant people. And again, in the context of my care, really focusing on pregnant people who do face barriers to their care. And my work really, the background that I have and really rely heavily on in this work is around human-centered design, community engagement, and cross-sector partnerships. And my training outside of my clinical training is around management and finance. So really focused on how we can use kind of available healthcare financing, both through the care delivery system as well as the public health dollars that exist around maternity care, to create new and sustainable models of care that are going to, again, meet the goals of being high quality and valuable. So in terms of my project, briefly, I'm one of the leaders of the Family and Pregnancy Pop-Up Village, which is here in San Francisco. And the Pop-Up Village is a cross-sector model of care that aims to tackle inequitable pregnancy care. And when I talk about inequities in pregnancy care, we're focused on access, experience, and then ultimately outcomes. And the way that the Pop-Up Village aims to do this is through changing the environment and the behavior of care delivery systems themselves. So what it specifically is a monthly event. And in this event, we bring together, it's essentially infrastructure that allows us to bring together all of a large number of pregnancy and family-focused organizations that deliver public health and social services in the city, CBO services, and clinical services to provide one-stop shop access. And there's really two key concepts within the pregnancy village, the pop-up village model. One is around environment, as I said, changing the care delivery environment. So the idea here is, as opposed to our current systems and structures that have been really built up around silos, you have the healthcare delivery happening in one place, and you have one CBO that offers food and another one that offers housing, that we really change that environment so it is a one-stop shop and it is community-based. So it's there, unfortunately, maybe I can pull up some pictures later, but really there it's not in the built environment. So it's outdoors, and again, a community event. And also really changing the physical environment. So there's the one-stop shop, but there's a lot of focus on design. So we work with designers who actually are focused on ending mass incarceration and thinking about systemic racism from a design perspective. So the concept that people cannot feel safe, they cannot feel that they cannot be in a place of trust if they are in a physical environment that is not conducive to that. So those are kind of the concepts around environment. So one-stop shop access, an uplifting space, and a lot of attention to what does it look like, particularly for communities of color, communities who have been impacted by racism and discrimination. What does it look like to build environments that feel safer? And then the second is behavior of the care delivery system. And so here, again, the one-stop shop concept is really around coordination, right? So rather than me as an obstetrician sitting in my office and doing my thing alone, I now am in an environment where the behavior is around me needing and wanting to coordinate with these cross-sector partners around their needs. So rather than writing a referral for housing, I'm sitting right across from my housing partners and can really do these warm handoffs, and that we can actually have these kind of three-way, four-way conversations with the person we're talking about right there in the midst of it. So thinking about it's allowing for coordination. And then we focus a lot in terms of behavior around literal interactions. So again, thinking about design, like how, when we're in a normal office setting, like for me as an obstetrician, how does the physical environment actually change my behavior? How does the way I walk in the room and the fact that I'm in a hospital or a clinic, how does that actually inherently set up kind of these hierarchies that actually my behavior may perpetuate? And so another kind of core principle of this model is that by changing environment, you actually have the opportunity to also change behavior. So we spend a lot of time with all of our partners really talking about how we show up in community to deliver services, and that we're showing up really first and foremost as human beings being in relationship that have a skill set and can help this other human being that needs help, rather than like, I'm a doctor walking in your room and I'm here to do my thing and I have 15 minutes to do it, which unfortunately is the reality of the other part of my life. So I think I'll just end there for now. I think that probably sums up what we're trying to do. I will just end by saying that the Family and Pregnancy Pop-Up Village, we design around the needs of the Black community, and it's an event that's open to anyone. But that design part, again, is really critically important, and that is our priority population, is Black pregnant and postpartum people.
Thank you so much for that overview. And it's a wonderful synopsis of what is being done with this particular research project. So appreciate that. Up next, we'll have Dr. Felix Muchomba talk from Policies for Action and the Mapping Maternal Health in New Jersey, giving us an overview there.
Hi, everyone. Thank you for joining us. My name is Felix Muchomba. I'm on the faculty of the School of Social Work at Rutgers, the State University of New Jersey. I have graduate training in public health and in social policy. And my research and really mission is at the intersection of these two fields. So very generally, my research revolves around the social and structural determinants of maternal health, maternal reproductive and overall health. And I am primarily concerned about people pushed to the margins because of structural disadvantages. Here I'm talking gender, poverty, immigration, race, what have you. I ground my work in in social justice, which is a core social work value, and particularly in the principle of health equity. And so I am involved in research that seeks to understand the role of social policies and social institutions, including those not directly focused on health, in generating, sustaining, and hopefully alleviating health inequities. So our Robert Wood Johnson Foundation sponsored project, Mapping Maternal Health in New Jersey, is an example of this. And this project, we are examining maternal health in New Jersey. Now, New Jersey is one of the wealthiest states in the nation, has one of the highest median incomes, lowest poverty rates, one of the lowest poverty rates in the country, and yet has some of the worst maternal health outcomes. We have one of the highest maternal mortality rates and one of the highest maternal morbidity rates in the nation. So our team sought to examine closely at this issue. So we looked at the geographic variation in maternal health in the state. We sought to identify, what are those municipalities, what are those areas in New Jersey that have worse or better maternal health outcomes, and then to seek out local policy solutions that support maternal health by looking at differences in these local policies in various domains, including those not directly linked to healthcare. So we were really curious in understanding what is it about these places that have either worse maternal health outcomes or better maternal health outcomes that bring about these differences. So we are really trying to understand, is there a role of place and what is it and how can we then intervene? We are using over 1 million birth records from New Jersey that we have linked to maternal hospital discharge records, as well as area level data from the census, from the state, as well as other sources. And we have focused on severe maternal morbidity rather than maternal mortality, because SMM occurs far more frequently than maternal mortality, and so allows us to have more generalizable conclusions. Yeah, let me stop there in the interest of time.
Thank you so much. Once again, a wonderful overview of the research. Definitely encourage everyone on the call, if you haven't taken a look at the links associated with these projects, to do so. And last but certainly not least, we'll have Dr. Venice Williams from Systems for Action talking about aligning health and social systems to expand evidence-based home visiting.
Thank you. Good morning or good afternoon, depending on where you're located. I'm Venice Williams, and I'm an assistant professor at the University of Colorado, based within the Prevention Research Center for Family and Child Health. And my training background is in community health and health services research. So I do mixed methods research, focus on maternal and child health, with a particular focus on implementation science and looking at how we can improve the delivery of prevention programs like nurse home visiting to support families experiencing the greatest adversities, and looking at how we can build better systems of care to enhance family well-being. So most of the work I do is kind of revolved around home visiting and prevention, but then thinking about it from a care coordination, cross-sector partnership standpoint. So working with communities, engaging with communities to gather their perspectives to inform the kind of practice of home visiting. So the particular project that we were funded by Systems for Action for is focused on evidence-based nurse home visiting, so specifically the Nurse Family Partnership Program. For those of you who aren't familiar with it, it's an evidence-based home visiting program for first-time parenting people, those who are experiencing socioeconomic adversities and other psychosocial adversities or risks. And so our particular project looked at how alignment of different sectors of public health, healthcare, and social services in terms of their delivery of NFP or financing of the program might affect outcomes for our families who are enrolled. And so mixed methods, we wanted to look at what collaboration looks like across different sectors. How does that change over time? How does that impact retention of clients in the program and subsequently their health outcomes? And then we wanted to focus in on best practices. So we used a qualitative approach to look at high-performing NFP sites with really strong collaboration to identify across these different cases what are kind of key factors that lead to better collaboration that then addresses the needs of the families that are in the program. So that is kind of a quick summary of the work that we do, looking at how different financing and delivery systems might affect how the program is implemented, and ultimately, improve the outcomes of the families who are engaged. So look forward to this panel and a discussion that we're going to have.
Thank you. Thank you to each of you for giving our audience a wonderful overview of the research that each of you all have been doing. So leading us into our first question, it is, what are the policy levers that are relevant to improving birth equity, especially levers that address structural racism and addressing disparities experienced by BIPOC and individual communities? And to start us off, we'll have Dr. Nijagal.
I love this question. So with policy, my mind immediately always goes to payment. And in this context, what I've been thinking a lot about over the years of studying healthcare financing, specifically in maternity care, is just the extreme amount of money that goes to healthcare payments, and specifically to a hospital. And so when we look at the dollars and cents that are spent, that we all know are very high, recognizing that so much of that goes to the hospital, and then in the context of this question of, how do we improve birth equity and how do we think about structural racism and addressing disparities, I believe very strongly that the place to do that is actually not in the hospital. Yet the hospital and that kind of birth episode, and even if we include traditional prenatal care into that and the money that's spent, I don't believe that that is where we're actually going to be able to make as much movement. And I want to be really clear here. It's not that we are not seeing inequities and disparities in those spaces, but I think when we really come down to the fundamental question of structural racism and what is leading to these disparate outcomes, number one, I think it's happening more on the outpatient side. I think or outpatient meaning the pre-delivery period is really critical in terms of reducing the disparities we're seeing that are resulting from inequities and racism. And number two, I don't think it's in the provider's office necessarily. And so in terms of policy levers, there's a few things I think about. Number one, I think we need to be able to use Medicaid dollars to improve access to care, things like transportation or other barriers that may prevent people from actually being able to get into their care. I think we need to be able to use Medicaid dollars to be able to broaden the type of care and support that people receive during their pregnancy. So that may be, what a lot of states are doing, thinking about things like doula care, thinking about community health workers that can help people navigate to the type of resources they may need to be more healthy, be able to be more healthy during pregnancy. But even things like food, healthy food access. And so really thinking about, again, more broad access to care and support that people need to thrive during their pregnancy. And then finally, I don't think this will come to as a surprise to anyone given the work of the pop-up village, but really being able to think about policy around or policy changes that allow for care to be delivered in different settings. And so when we look at Medicaid policy, or in our state, Medi-Cal policy, we really need, those three things are lacking. I do think that we're very lucky in California and that we have a new program called CalAIM, which really is starting to make these moves and is really thinking about the role of Medicaid around, quote unquote, social determinants, or just kind of a much broader vision of what health is outside of traditional healthcare. But that's really what I think is where I think is a huge place to focus, is Medicaid payments.
Wonderful, wonderful points there. I'll hold even my questions until after, where I did highlight some key points you mentioned. Dr. Muchomba, how about you? Any thoughts about this question?
Yeah, I tend to agree with what Dr. Nijagal said about this, the importance of the social determinants of health. And yes, the hospital is important, but what's happening out in people's lives outside the hospital is vital. And so an important finding from our work is, number one, is that there's wide variation geographically in maternal health outcomes. And so we are finding that place matters, that where our birthing people live or have lived, leaves an imprint in their bodies that is then connected to their outcomes at birth. So for instance, our research is finding that in New Jersey, the municipality that has the highest rate of severe maternal morbidity had over 3 times the rate of SMM compared to the municipality with the lowest rate. So there's really a need to have local or even localized solutions if you're trying to get at, what's happening at where people live. So what's an example of this? One thing that comes to mind is that there's a lot of attention on federal government policies and also, to some extent, state government policies. Little attention is being paid to the role of local government in maternal health outcomes. Yet it is, I think, harder to change federal government policy. Local government has been largely ignored, I think, in the research and messaging. And this, to me, is surprising because municipalities are responsible for government action that you are more likely to interact with on a daily basis. So things like the crosswalks and sidewalks people use, public health messaging and programs, fire protection, ambulance, collection and disposal of garbage and sewage, like safety inspection of services and buildings and establishments, schooling, parks, policing, and they spend huge sums every year on such services. So, so our research is just saying, we need to pay attention to this. So in our research, for instance, we find that birthing people residing in localities that spend more on social services generally, and on specific social expenditures here, housing, public health, public welfare, transportation, and even libraries, for instance, have better outcomes. We also find that these same social expenditures at the local level are also associated with narrowing of socioeconomic disparities in severe maternal morbidity. And housing is a good example of this. We are finding that birthing people who are living in areas with high rental costs relative to income were more likely to have SMM. And we also find that providing more affordable housing actually attenuates or weakens this link between housing costs and SMM. And in addition to that, we also find that affordable housing can also be a lever for improving equity. Projections from our research, for instance, are indicating that each additional $1,000 housing subsidy per year per person would narrow the disparity in SMM between the most educated and the least educated by as much as 20%. So there's really a lot to be gained, I think, from looking at these local levels policies. However, I will say that to more fully address, the issue of, say, a housing cost burden, for example, and really address racial disparities, it would be necessary, obviously, to address, go further upstream and address those broader factors that intersect with housing costs, things like redlining and other manifestations of structural racism.
Absolutely phenomenal points there. Thank you so much for that thoughtful response. Dr. Williams, turning it to you to give your reflection.
Sure, I agree completely with Dr. Nijagal and Muchomba. It's the reaching people where they are, right? And addressing social determinants of health, which is why many of us do the work that we do. And so I think in both of those, to address both of those, no surprise, I'm going to talk about home visiting, right? My project, but what are policies that can improve the reach of these evidence-based services that are able to meet these individuals and families where they're comfortable, where they feel safe? It's called home visiting, but it's not always in the home. And that use approaches that are family-centered, that are trauma-informed. And so what are policies that can be implemented to continue to support these programs? At the federal level, there's the MICV, the Maternal Infant Early Childhood Home Visiting Program, which has bipartisan support for the most part, but we've got to renew it every however many years. And there's a lot of efforts to get there. So what can be more sustainable policies that can continue to support and fund these programs that can reach these families where they are? To Dr. Nijagal's point about Medicaid, there's a lot that can be done there, I think, for reimbursement of services and so forth. But I think when I think about policies, there's a big P, which is government, so federal, state, local. Then there's a little p, which is what, at the organizational level that can be done. I think so. Obviously, we would love these multi-level kind of interventions to happen. So I think at the smaller, kind of more organizational level, is thinking about culture change, not just provider bias education, right? Like we hear that all the time, but what can we change at the organizational level, even from whom we're hiring, what are the environments we're creating to promote psychological safety? How do we diversify our workforce? What are those things that can be done at the organizational level to ensure that we're meeting the needs of the communities that we're supporting and serving? I think part of that also then is promoting cross-sector collaboration and care coordination. Are there financial incentives that might motivate that? And so those are kind of some of the examples like I've kind of seen from and heard from throughout our projects. For example, when nurse-family partnership is embedded in health systems, we see them tend to do better in retaining clients. They're seen as part of the kind of broader system of care. Even though they're conducting visits in the community, they're connected to this broader resource network, in those ways of being able to communicate with healthcare providers and so forth. At the same time, the healthcare providers are knowledgeable about these community services and what these particular programs can offer their patients. So I think it's some of those kind of strategies that we're starting to see that can really address kind of disparity issues, access to care issues. So I'll just leave it at that for now.
Definitely appreciate you bringing in the importance of little p as well, because it is often that most folks consider federal and state and so forth as policy issues and sometimes doesn't focus on organizational policies that can also have an impact. So for question 2, we are asking, what are the key partnerships or collaborations you've identified that empower community members? What learnings can we take away from those collaborations, particularly about next steps to make sure communities are engaged and aware of the findings and improved outcome recommendations? And to start us off, it'll be you kind of coming back up, Dr. Williams, to share your insight on this question.
I feel like I'm talking a lot, but it was just for this portion of the panel. I love this question. I think it just so resonates with the work that I do is how do we integrate community voice into the work that we do? And for our project specifically, it's really family voice or parent voice is what we kind of, think about in terms of the community we're talking about. And I think in the ideal world is they would be engaged from beginning to end of any research project. In reality and in funding, that rarely happens. But I think that's what we strive towards. So from designing our research questions, our study design, what outcomes are important for families to think about, or what's important to them, all the way to dissemination of our learnings and our kind of recommendations for moving forward. So for this particular study that was funded through Robert Wood Johnson Foundation, we were able to interview and engage with current clients in the NFP program, as well as past graduates, particularly those who experience care coordination. So we wanted to kind of compare their perspectives to the nurse home visitors, to the community providers, and triangulate everything that we heard. What's consistent, what might be not, and kind of what are their perspectives and how did they see things happen from their view. And this is, involvement, and participation and engagement. We're hearing from them, we're learning from them, but that's how much of that is really informing like the work. I think that's where we could have done a little bit better. And that's what we're trying to do in future projects. And another project that we're working in really focuses on trying to build leadership with the parents. And so we include them in our advisory board, those with the lived experiences. How do we build trust and with these community members, right? I think it's respecting their experiences as their expertise. and creating opportunities for them to share their experiences, not just on the board, but something we've done is we download after the fact with them to see how we could have improved their engagement better, and providing folks with tools to succeed. And so we conducted some training and education with them about research and evaluation, like what are some of the terminology that we'll be going to be using, what is research, what is evaluation, how can we support you in making sure that you feel heard, that you feel confident in sharing your perspectives. Compensation, obviously, is important, whether that's through stipends or contracts, not just for their time, but also because we're working with parents, covering their childcare costs, covering, potential access to technology. So if we're meeting by Zoom, what is their platform for being able to do that? Do we need to provide tablets? Do we need to consider reimbursement of their data plans? If they're going to be using data. So I think it's a lot of the kind of not typical things we think about in research, to think about what are ways that we can uplift communities and uplift our families, so that they feel like a leader, that they're contributing to the work that we're doing. So we've been able to invite some of our parent leaders to co-present with us at conferences, help us in creating products for dissemination. So what content should be on a flyer, for example, or a kind of pamphlet type thing. So I think those are some of the examples of things we've done to kind of, how do we think about engaging communities, not just in the collection of the research, but then sharing what we've learned.
Absolutely. And thank you for elevating issues like addressing digital divide in your response, for making sure that the platforms and technology is there for participation and, of course, compensation. Okay, Dr. Muchomba, it's your turn to go ahead and let us know what thoughts you have regarding this question.
Yeah, I'm happy to share some of the few learnings that I have had so far. The first is the need for continued relationships. Okay, I am a man with a strange accent, and here I am talking about maternal health. And so the way for me to develop rapport and cultivate trust with community members and stakeholders requires that I keep showing up, that I keep having these important conversations, that I keep listening. And that has been really crucial. Really, my messaging is going to be compromised if there's really no trust, and I will not get to hear from the community if there's really no trust. Another thing that I have learned is the need for multi-sectoral partnership. The challenge of doing work around structural determinants of maternal health is that this sector overseeing maternal health is not the one that's overseeing the structural determinants of health. So for example, I was just recently talking with a physical therapist who works with birthing people recovering from birth complications. And she was sharing about her efforts to address barriers that hinder, people who need such services from accessing them. And the barriers are primarily, non-medical, things like transportation and childcare, etc. And it is by engaging in multi-sectoral partnerships that I think where the synergies of addressing structural determinants of health become more visible. When you have people from different sectors sitting together at a table, then they can actually see that there's a lot of dividends to be reaped from actually addressing structural determinants of health, not just for health, but also in other sectors. And I also really tend to agree with Dr. Williams' point about going where the people are. And so for me, this has looked like connecting with more local maternal health advocates, going to community gatherings, okay? And I have, through this process, found allies in different places, some of them unexpected. For instance, there's one radio journalist who has been very interested in our research, and it turns out it's because that, his wife is a doula. And so his wife has been making it clear to him about the issues that she's seeing as part of her work. And so it's great that there's that doulas out there are promoting the message around the importance of maternal health. And it's great for me to talk to people like the radio journalists who understand the significance of the issues, who are then able to help me translate this research into language that people can understand and can relate to. And it seems to work. And it turns out that a large number of people, at least in New Jersey, listen to the radio. I have, and I know because people have come to me saying, hey, I heard about your research on the radio, let's talk about it. And so And so I'm all for that. And so to support the work these various advocates are doing, I am using traditional peer-reviewed publications, but I'm also using more accessible ways of engaging with the community for presenting these findings. So, this is your press releases, infographics, public websites where people can come and navigate and understand the findings, because I really think it is important for community members to have access to these findings, for community members to understand them, to ask questions, and for us as researchers to work in partnership with them to refine some of these research practices that we are engaging in.
Thank you. Thank you. Once again, great points. Definitely appreciate the multiple avenues utilized to engage communities about the findings that are a part of the work that you're doing. So Dr. Nijagal, we are passing the mic to you now to, share some of your insights as well.
So just to start with a little structural distinction or a point about our work. So we kind of have two arms of our work. One is the production of the pop-up village, and then the other is the research effort. And I make that distinction because it's really kind of critical in terms of when we think about the partnerships and collaborations, and we certainly think deeply about them on both sides. Everything that Dr. Muchomba is saying about trust is just really critical. And I want to also quickly say that while I am here presenting this work, I am certainly not the leader of the work. And importantly, the pop-up village it took 3 years, it was actually 4 years in the making from the time we started developing the model to the time we rolled it out. And in those 4 years, it was really the development of these cross-sector partnerships. And what was so critical from the beginning is that UCSF, which is where I work, and we were involved with a lot of the early human-centered design work that kind of started conceptualizing the need for this model. UCSF could not be the one leading this. Why? Because of trust, right? So we already know in our community, UCSF, this precedes me, it precedes all of us, but it's an academic, this is nothing against UCSF, but it's an academic institution that has caused a lot of harm over the decades and decades. And so UCSF coming in and starting a model like this would not be a good way to start from the get-go. So the trust and partnership thing is huge, trust and trust, I'll just say that, trust and how we truly partner with community or do institutional community partnerships in a way that is different and I'd say more equitable in terms of decision-making. In terms of decision-making, I'll leave it at that. So I think the key learnings for me, and I just want to kind of put on my identity really quickly here because it's so critical to this. So I am a physician, I'm a professor, I'm a non-Black person of color who is coming into this work, having done a lot of the early development work. And I'd say one of the key first things was really trying to work on relationships in the context of my identity when I was with community partners and others, to be really clear about what is it that I could actually provide, where should I be kind of stepping up and being kind of more central in this, and where should I be stepping back? And I think that was really critical for all the people on the team coming from the institutional side. So that's the one thing that I would say was critical. And again, that wasn't like a one meeting, right? I mean, that was going on for years, right? About really this relationship building and getting to a place, again, as Dr. Muchomba said, of true, genuine, trusting relationships and transparent relationships. And then I'd say, the learnings from that over the years have been really around, I don't know that I'm going to be able to share anything brilliant, but I will say that I came in thinking as long as I'm really, transparent and very self-aware and all of that, we build a very strong, trust from the beginning, then everything will be fine. And what I'll say is it's been really challenging. So it's been amazing. I think we've been able to accomplish some amazing things. And when I say we, I'm talking about, again, the institutional partners and the community partners. But at the end of the day, the truth is there's decades of history, there's decades of mistrust, and and people come in with assumptions, including myself. I'm sure I come in with assumptions. And so I guess my main learning has been, it's not like this phase of relationship building and then you're good. I think that has been my experience in institutions. I come into an institution, I build relationships with my colleagues, and then there's just a foundation there and it feels kind of not so challenging. I'd say that has not been true in our experience with pop-up. And I think it's the beauty of it, and it makes it really rich because you're constantly thinking and trying to understand dynamics and how they are both really advancing the work. The differences advance the work, and they also just bring constant challenges that are unexpected. And then the only other little thing I'd say in terms of just kind of jumping on to what I think Dr. Williams, you were talking about before, is that's with community partners. Then the question is, how are you engaging the people that you're doing the thing for, right? Like the people who are in our vision, benefiting from the pop-up village model. And that also has had challenges in that we have, we've tried to do all the things, we have provided funding for people to be on our team. We really compensate people well for giving their thoughts and being kind of decision makers in what we do. And it's actually just been really hard to get people to engage in a meaningful way. And so again, lots of challenges that I don't have any brilliant solutions for. But just to say that it's, as someone told me in the beginning, if the work doesn't feel really hard, you're probably not doing it well. So that would be my kind of final comment on that.
Definitely appreciate those insights, and also the emphasis on, the 4 years associated with developing the work. I think that is important thing to consider when it comes to some of this effort in building relationships. Is some of it's not going to happen overnight, and so having time is a wonderful element to help build that. So question 3 is, what are your plans for translating evidence into action, and what recommendations do you have for others who are interested in implementing similar interventions? Dr. Muchomba, you'll kind of start us off there. I know you gave us a little bit of a preview in your previous response, but looking forward to hear more.
Yeah, it's a great question. I would love to see our work translated to action and in turn translated into health equity. So first, I have been pursuing traditional avenues, traditional academic research avenues. And the motivation for doing this is that there's actually very little research on how local government policies are connected to maternal health. And so the idea that municipal policies affect health or health more generally is new to many people. So I have been planning to share these findings with the scientific community and with funders like Robert Wood Johnson to really spur more research in this area. So it's no longer a surprising idea that policies where you live really affect your health. So that's one traditional route. And I've also been, again, trying to work even more closely with maternal health advocates. And a lot of the ones I have talked to are not surprised by our findings. In fact, many of them have expressed many of their ideas for their own ideas for implementing interventions. They are very passionate about their work. They're already in partnership with their communities. And so really, how can we support them? And so the question I've been asking a lot of myself is, how can I be of support to these advocates already doing a lot of the work that I'm also engaged in? And what they have been looking for is the resources to do their work. Some of them, reach out to state governments and not getting the assistance that they seek. And so my plans really will involve more continued partnership with these above equity advocates, with our team offering any expertise or resources available to us, and then helping them advocate for more sustainable funding mechanisms. And then because our research suggests that, municipal level policies, at the local level do matter. In my conversations, I have been asking, and I will continue asking about policymakers at the local level. We are talking municipal government councils, school boards, mayors, and so on. And so, for instance, as a result of these conversations, I have been invited, for example, to have a community meals with, say, people running for mayor against the other incumbent. And so these kinds of avenues, I think I will continue pursuing them because it's important to have these conversations that could potentially amplify our research recommendations. I think one thing I will say finally is that if our goal is to intervene at the local government level, we need to get engaged with the local policy process in partnership with our communities. So this basically means building relationships with policymakers. So for example, we need to find out, for example, how is a municipal budget put together? And we want to have those conversations early, because by the time the budget is presented to the public, it's often too late. So start building those relationships early, get into the process, get engaged in this process early if you're interested in intervening in this manner.
Excellent, phenomenal points there. Thank you so much for that insight, especially around being intentional on the research around local policy, because that does have a significant impact. And the work that you've done here does arm a lot of organizations with that information. That's oftentimes what local organizations are seeking, is local data. So next to give insight will be Dr. Williams.
Yeah, I think this is why, at least I do the work I do, right? It's not just to do research and put it on a shelf. And publishing is part of my job, and we will do that. We will, from an academic perspective, present at conferences, get the publications out for this particular project. I think measuring cross-sector collaboration is novel. It's newer. Looking at how that changes over time. So like the measurement itself, I think is a practical use for the field, and then tying that to outcomes, because oftentimes we hear about, like, we should be doing this, but does it really improve particular outcomes? So I think from a scientific standpoint, there are definitely those results that we are going to be sharing from a scientific perspective. I think for me personally is how do we integrate what we learned, the best practices that we heard about, into practice for our nurse home visitors, and our local network partners, our local NFP sites that implement the program. So this dissemination with our practice partners, I feel like, has been so important for this project. We're lucky that we had this collaboration that Dr. Nijagal talked about. It takes years, right? It's many, many years of relationship building and trust, and maintaining that relationship, but being intention about including them from the beginning, sharing progress early and often. So I feel like as researchers, sometimes you want to wait until like, oh, we have the final modeling done, or like this is what we're seeing at the end, and kind of worry a little bit kind of about the interim findings. And so I think that's something we've been intentional about, is including our partners, kind of sharing these results earlier on, monthly, quarterly meetings, lunch and learns, those kind of avenues that might include different representation from our National Service Office, that might apply to the work that they do. And so we also had our advisory board member participate on one of these research in progress webinars with us to reflect on the work that we're doing. So those have been a few things that we've worked on. Future plans, I talked a little bit about creation of products for dissemination. So I think, like case, briefs, infographics that Dr. Muchomba talked about. What are kind of different products that might be more digestible for different audiences? So working with our local university, like thinking about marketing and all that, since I'm not as great with that kind of work, like, everybody has their own strengths. I think it's like, how do we leverage strengths of others and other departments, and kind of integrate that into our work is kind of our next steps for this project.
Awesome. And thank you for sharing about the different avenues in which you're getting the information on out. All right. And so now we'll have Dr. Nijagal go ahead and let us know what efforts you all have around translating the evidence and recommendations.
Yeah, so I mean, a huge shout out to both Robert Wood Johnson, Evidence for Action, as well as my unbelievable, our research PI, Dr. Patience Afalani, and her team. in that we really have developed a research design that allows for us to iterate the model in response to what we're learning, and then iterate our research or our methods and also in response. So, I am not a researcher, so I really understand how that's being done, but they have done it, and I think it's extremely challenging. And again, I really want to give a shout out for Robert Wood Johnson, because when we were applying for this, I think they were a little thrown off by what we were trying to do as well. But to Dr. Williams' point, we really don't, we can't sit on what we're learning and not change and be responsive with the model, because the whole point is to to improve care in real time. So that's one thing. I think, what I'd say about how we're disseminating, similar to Dr. Williams, of like, how are we really helping other communities and what do we put out there? What I feel really strongly about, being someone that has done implementation and systems change for all of my career thus far, is the how, right? Like how, and I think there was a question in the chat about this, like, I love reading studies about how amazing a program is, but where my brain goes is like, but how do you actually do it, right? So that's a huge focus of mine, is writing really the methods, like how did we bring together the partners and what happened? What were the really big challenges that happened and how did we overcome them? Again, not that our solutions would work for everybody, but the how feels really, really important for me. So we are, that is kind of one aim of our research, is not only to look at the outcomes and what we're learning from community members and from the participating partners, but actually to really document and disseminate around our processes for this type of cross-sector collaboration, to help to food for thought for others that are diving into work in their own communities.
Excellent, excellent. And definitely wonderful emphasis on the how-to aspects. I think that is a excellent leverage point to guide folks who, take the information here and want to either replicate it or ensure that they're being as intentional. So all of you definitely provided such great feedback on ways that you are translating the evidence and connecting this and dispersing it out, so that way we don't continue to sit in this lag between research and when it's an actual implementation. So wonderful forward movement. Going on. So we are now here at the question segments. Time goes fast when you're having fun. So we're at about 53 minutes into the hour. So we do have, some great opportunities to hear from the audience here. So I do have the questions parsed up here. The first question I see is, how are doulas being integrated into the projects? And I'll leave that for anyone who feels moved to answer.
I can start with that just for the pop-up village. We have 2 doula organizations within San Francisco. Both of them are core partners in the pop-up village. So core partners means that they come to every event, they enroll clients, and we actually just started, we recently learned that there's no free birth classes anymore in San Francisco, and so we decided that Pop-Up Village is the perfect place to offer and support that service. And so one of our doula organizations is really taking that on as the organizing entity to ensure that there always is a birth instructor there. So they're very, very intimately involved in the Pop-Up Village.
Well, and so evident of how much of a relationship you have with the community to be able to elevate quickly when something is missing, such as a resource like the free birthing classes, and be responsive. Anyone else want to respond to this question? Okay, so we'll go on over to the next question, which is, where is the date? Oh, wait, it disappeared right in front of my eyes. Okay, so we'll go down to the
I'm
next.
so sorry, I just typed an answer to that. I didn't, sorry about that. I was pressing, I typed it and then I pressed return. I didn't know it was
Okay, so I'll move down to the next question. Actually, this question is also for you, Dr. Nijagal, which is, I am so curious about your pop-up village. Where I am, we try to physically co-locate the agencies of public health, social services, and community health center, and couldn't make it happen. The aim was the same as you described being behind your project. Did you try to co-locate the agencies in a brick and mortar space before opting to go to a pop-up? If so, what were the challenges?
Yeah, thank you for that. We did not. And there's a really specific reason for that, which is the brick and mortar spaces that would be available to us are all one organization, would be kind of owned by one organization. And the nature of Pop-Up Village is actually that it is not owned, it is not led by one organization. And I think, I could go on and on about this, but at the end of the day, there's a lot of, even in the CBO world, there can be a lot of competition. And so when you locate something within the walls of a specific organization, it does change the nature of like this true, what we're really trying to create is just infrastructure. And really, like I would say, it's not run by the city, but ultimately the vision would be that the city should be at least paying for, not running, but paying for infrastructure that allows all of these different organizations, whether you're a CBO or a government entity, to come and deliver their services. That the advertising and the space and the setup is all being taken care of, but you can actually all come together and do what you do, but now have the opportunity to collaborate. So no, we intentionally decided not to do it, though that would have been, it probably would have been less than 4 years in the making. But yeah, that's how we chose to go about that and why.
Thank you so much. For this next question, I think everyone may be able to give response, which is when trying to build trust with communities, how do you practically address and acknowledge the harm done to communities by institutions?
I can say a few words here. I think this is a really important question. And I just want to say that it's easy to just give empty words, and words can often be hollow. The way I see it, acknowledgement of harm really means that, we are doing something about it. It really means that we are, for me as a professor, I am using my power that I have to talk to my institution to advocate for change. I really think advocacy really requires action. And so as somebody who has a status in an institution that, has historically been engaged in practices that are harmful, so that for me means using my power to really to perpetuate change within my institution. I know there are also folks who will say, really practically addressing and acknowledging harm means that you are getting as close as you can to these communities that have been harmed. So it's easy to have words when you live in a nice, nice neighborhood, when the folks who, for instance, are having to deal with these inequitable policies, live in a different segregated neighborhood. And so how are we bridging that gap? Where are you living? Who are you surrounding yourself with in your daily life? And so that for me really means, again, action.
Thank you. Anyone else would like to respond?
I can just say, totally agree with Dr. Muchomba. One of the ways, a very tangible, practical way that I've been focusing on this is through funding. And it's really challenging, but especially being an institutional person, that frankly, because I'm an OBGYN as well, like my salary is, good, high. A lot of transparency with fundraising and actually trying to build trust by fundraising in ways that will not come back to me or the institution at all. So I'll do like a lot of fundraising and then direct like 100% of those funds to a community partner, which is super, super challenging on a practical level. But I will say, like, it's so tangible, and it really, at the end of the day, institutions for good reason, have the reputation of taking and then like giving, taking a lot and giving a little. And so I think being kind of trying to be extreme, the opposite, has been helpful and hard.
Yes, thank you for that insight. And just checking in, Dr. Williams, did you want to give any insight?
I mean, I don't know if I have much more things insightful beyond what was already shared. I think I think it's being authentic and truly you. Well, the people who do this kind of work, I feel like it hits us in a different way. And it hits us to our core. And I think for me, being a person, I'm a first-gen immigrant, I'm a first-gen college graduate, and that's who I am. It informs how I do my work. And the experiences I've had and the struggles I had informs how I relate to others. And so I always think about it, okay, I've made it this far. How do I uplift those around me to achieve their goals? And whether that's like from an institutional standpoint of working with my project managers, my research assistants, to the community, where I just want to support people in achieving their goals and whatever means and tools I have to get them there. That's what we'll do. And I'm pretty straightforward person, and we'll real talk, I don't kind of like use special language or anything. And so I think it's just, just being true to who you are. And that's where people see who you are, and then they're more comfortable in being themselves as well. And that's one way to build trust and hopefully address these kind of systemic issues and acknowledge the past and so forth, but moving forward with together.
Thank you so much for that. And I feel like that last question was a great question to close out the Q&A segment with. And we are here at time, just a little bit beyond time. So thank you all for staying in just a little bit longer. We have to give acknowledgements for the Evidence for Action, Policies for Action, and Systems for Action, our national program offices of the Robert Wood Johnson Foundation. So thank you all for this time. Thank you all to our panelists for your very insightful feedback. I personally took a lot of notes, so appreciate everyone, and have a great rest of your day and stay safe.